ARDS is predominantly an ICU level topic, but it is a great opportunity for the test to test you on pathophysiology, leading back to more the step 1 content rather than what's the next best step. So I want to talk to you about ARDS at the MS3 level, focusing primarily on the pathophysiology and a little bit on diagnosis. We're going to touch on some real life stuff, but if what you want to know is how to handle ARDS, check out the intern content, Lung Protective Strategy. Let's start off with what the lung looks like in ARDS. Normally you've got this capillary and a bunch of alveoli are right up against it. In the alveolar capillary membrane, really tight. If you zoom in, what you'll see that there is a very small barrier to diffusion between the alveoli and the capillary, such that oxygen has no problem getting across this membrane. Nor does CO2. Oxygen is diffusion limited, which means that the bigger the barrier, the less the oxygen can move. CO2 is perfusion limited, and therefore it doesn't matter what the diffusion barrier is. So what you're going to see as we move forward, that ARDS is all about oxygen. This is normal, right? The alveolar capillary membrane is small, oxygen can diffuse no problem. In ARDS, which is defined as a non-cardiogenic pulmonary edema, and you're going to hear me say those words a lot, non-cardiogenic pulmonary edema that's not from hydrostatic forces is caused by leaky capillaries. And so this capillary now lets fluid out, fluid that's not supposed to be there. And what happens is this is a very confined space. So the fluid leaks out and crushes these alveoli. So the alveolar capillary membrane looks something like this. The alveolus itself is small, and it has all of this fluid sitting around it. This is microscopic now. So if we zoom in again, what we see at the alveolar capillary membrane is a bigger diffusion barrier to oxygen and less surface area in contact of the alveolus to the capillary. This makes it very hard for oxygen to get across this barrier, where CO2 is perfusion limited and has no problem. So hypoxemia is going to predominate in ARDS. You should suspect ARDS in patients who have reasons to have leaky membranes. The person is going to be sick as shit, and they're going to be hypoxemic. But you want to look for the person who's in septic shock, has a transfusion-related acute lung injury, or is a victim of a near drowning. Because this is all about oxygen, they're going to present with acute hypoxemic respiratory failure. In particular, what you're looking for is a P to A ratio less than 200. And they're probably going to give you the chest x-ray. Right, this is the person who's short of breath, hypoxemic, on a ventilator, already super sick, and you get a chest x-ray, and the chest x-ray shows you pulmonary edema. Now you are going to be given the option on your test to get a pulmonary capillary wedge pressure, Swan-Ganz cath, pulmonary catheter, whatever the case may be, it's wrong. You don't need it. ARDS is a clinical diagnosis made with hypoxemic respiratory failure and pulmonary edema on the chest x-ray. You don't have to do any invasive testing. But the test may ask, do you know what non-cardiogenic pulmonary edema means? And what they're going to ask you to do is compare CHF to ARDS. And they're going to give you the pulmonary capillary wedge pressure data as well as LV function. Now, the LV function can be assessed in real life with a BNP. If it's elevated, probably heart failure. If it's low, probably not heart failure, or an echo. But often you don't have time for these tests to intervene. So the test is going to ask you, do you understand what non-cardiogenic pulmonary edema means? Well, in a cardiogenic pulmonary edema from LV failure, the LV function is low. And since fluid backs up before the broken pump, fluid's going to back up in the pulmonary veins. It engorges them and increases hydrostatic pressure, and that causes the fluid to leak out. The pressure is high in the venous system, the pulmonary capillary wedge pressure will be elevated. In ARDS, because it is a non-cardiogenic pulmonary edema, the LV function is probably going to be normal or elevated. Because there's an acute illness, the heart's trying to keep up. So the LV function may be increased, tachycardia and increased contractility. And because all this fluid is leaking out of leaky capillaries and they don't have backup of fluid, the pulmonary capillary wedge pressure will be decreased or normal, knowing that ARDS can also have normal values. You should not do the pulmonary capillary wedge pressure, but you might get asked to interpret the results. To treat ARDS, the goal is intubation. And you want to manage two things. In terms of CO2 and pressures, you want to keep the tidal volumes low to reduce pressure and the respiratory rate high so you don't accumulate CO2. In terms of the oxygen, you want to use PEEP, positive end expiratory pressure, more so than increasing the oxygen. You don't want to increase the FiO2, you want to increase the PEEP, but you have to use small, shallow, fast breaths to maintain the CO2 levels. The most important thing you can do for ARDS is treat the underlying disease. But because this is hypoxemic respiratory failure secondary to a pulmonary edema, you can try diuresis. But ARDS-NET protocol is all about PEEP, positive end expiratory pressure. How does that work? Let's look at these alveolar capillary membranes one more time. This is the bad one. All that fluid leaked out, and all that fluid started to crush the alveolus. This is said to be de-recruited. And until the insult is over, that alveolus is not coming back. What you want to do is keep good alveoli open. You want to keep them like this. There's still that fluid force coming from the outside trying to crush the alveoli. But if you apply positive end expiratory pressure, there's always positive pressure regardless of inhalation or exhalation. You can apply back pressure to maintain recruitment. The de-recruited alveolus has a large diffusion barrier. Oxygen can't get through. The recruited alveolus has a very small diffusion barrier, so oxygen can get in. And of course, if you apply also increased FiO2, you increase the amount of oxygen diffusion. Okay, we touched on stuff in ARDS. If you want to know more about it, see the intern content, ventilator protective strategies. The focus is on the management of ARDS. What I want you to see is that this is a pulmonary edema that causes compromises of oxygen in a really sick patient. And what you need to do is be able to differentiate someone who's got heart failure from non-cardiogenic pulmonary edema. That's ARDS.